Hello friends. So today we are discussing about osteotomy and at the level of tibia and how we can help our patients by doing osteotomy. So the three most common type of osteotomy that I perform is one is an open wedge osteotomy. The second is a TCVO. I'll be coming to that. And the third is a slope correction osteotomy. So these three osteotomies you should always remember and you should know where and how do we do it. So if this is your tibia and this is the fibula, so the osteotomy level you need to see. The first osteotomy is usually made at this level. This is called as a high tibial osteotomy. Now this distance is usually 4 to 5 centimeters and we are aiming at a hinge point at a medial point to the proximal tibiofibular joint. Okay, proximal tibiofibular joint. So this is the hinge point of the osteotomy. What is the hinge point? The hinge point is the level at which we will be opening the osteotomy per se. So this is called as a high tibial osteotomy. This is an open wedge and we will be opening this. Now how much to open? We can calculate by two techniques. So if you see, if this is your hip joint, and this is your ankle joint. So there are two methods to calculate the correction. The first method is called as the Dugdale's method, in which what we do is this line and this line, okay, and we take this angle and this is the angle of correction. So this is called as the Dugdale's method. So the center of the hip, this is, what is this point called as? Fujisawa point. Now what is Fujisawa point? How, at what level is the Fujisawa point? That is very, very important. So the classical Fujisawa point that is described is approximately at about 65 to 70 degrees. 65 to 70%. This is a classical described by Fujisawa. And now recently this point is now been shifted more medially. So Dugdale says that to come more medially like this, and now recent studies have said that you should have it around 55%. Why? So recently we are shifting the Fujisawa point more medially. Why? Because this will lead to more overcorrection, more sort of change of a normal anatomy, and more patellofemoral joint problems. If you overcorrect it much higher. And the other thing nowadays we are doing is restoration procedures. So we are many times performing the surgery, osteosurgery with a root repair and extrusion repair. So in that scenario we don't want to correct that much. So we don't want to keep it into valgus, but we want to restore it to the normal level. So we will do the extrusion correction and the root repair along with the osteotomy sometimes. And we can do some kind of cartilage procedures like microfracture, mosaic plasty, something like that. So we don't want to correct it up to 65 to 70 degrees, but around 55% is a good mark, and that is usually corresponding with the lateral tibial spine. Okay. So this is the Dugdale's method. Another method is called as a Miniashi method. What is Miniashi's method?
He measures the depending on the height.
So it's basically a trigonometric method. So what it does is, say this is your fibula. So what it does is, say it connects this point to this point, and then your correction angle here, the angle that you plan to do. So this distance to this distance, the same value. This is the hinge point. From here to here you make the same point. And the same angle you make this. So this angle is similar to this angle. This is the angle of correction. So this is a trigonometric method in which, what is this line called as? Weight bearing axis. This is called as a Mikulicz axis or a weight bearing axis. So this axis you need to draw from the center of the hip to the center of the ankle. Initial pre-op, and then what you aim, the pre-op, post-op. And these two values at the level of the ankle, this is the projected level. And this projected level is, now this line is drawn to the hinge point, and at the hinge point you make the same angle. And how much is the mm opening as compared to the degree.
1 mm per degree.
It is up to 10 degrees. So if you want to do a 10 degrees correction, 1 mm is equal to 1 degree. After that it is increased. After that this is not true. So, and usually up to 10 degrees correction we don't want a bone graft or a substitute. After, if you have more than that, you need a bone graft or you need a substitute. So this is about open wedge osteotomy. What is TCVU and where it is used? What is TCVU and where it is used? Transcondylar valgus osteotomy. Now this osteotomy is used when you have an increased angle. So sometimes what happens is because of some medial condylar fracture or something, this angle is increased. So if you make an angle from a tibial spine to lateral tibial plateau in the middle tibial plateau, this angle is increased either because of a depressed medial tibial plateau or otherwise. So you do an osteotomy at this level. So this is a single condylar osteotomy. It goes through the condyle and like this, and you elevate only one condyle, and so you rotate it like this. So what you do is you actually correct the angle. So middle condyle lateral. If this is spike like of a tibia and you have a tibia, specifically this is specifically useful in a depressed medial tibial plateau fracture, fully condylar fracture. It is depressed, malunited. It is very useful. And the other is it is also useful in osteoarthritis cases in which you have subluxation. You can improve the subluxation better because you do a single condylar osteotomy. Otherwise, this osteotomy is a stable osteotomy. You can correct it and you can fix it with the plate. The other things are similar, but you do a single condylar osteotomy. This is a transcondylar valgus osteotomy, and this is also a very good osteotomy for knee restoration. The third type of osteotomy is called as a slope correction osteotomy. So nowadays it is known that if this is your lateral view and this is, so if your slope is negative, the patient will have a PCL sort of a symptom. So now what is the normal slope of tibia? 7 degrees, approximately 7 degrees, plus minus 3, 4. But if this is a negative slope, the patient is predisposed for PCL problems, PCL injuries. So if there is a malunited tibial plateau which has a reverse slope, or any PCL case in which you have a reverse slope, then it is better to do a opening wedge osteotomy. So what you do is you do an osteotomy like this. So you do an osteotomy from here, anterior to here, and then you open it up. So opening wedge osteotomy is for a PCL deficient or a posterior sag, or because of if there is a patient has a decrease or a negative slope, you can do a slope correction osteotomy. So you do it both the sides of the patellar tendon, and the hinge point is here. Hinge point is on the posterior tibial cortex as compared to the hinge point on the proximal tibiofibular joint on the opening wedge osteotomy of the STO. This is the hinge point here. So this is, we do it for a slope correction osteotomy. This is for PCL. The reverse can be done for a ACL. So ACL, you do a closing wedge osteotomy. Same. These kind of osteotomies are now more performed for a revision scenario in which if you feel that the tibial slope is increased. So if you feel that this is a tibial slope like this, then you need to do a closing wedge osteotomy, and this is more useful in sort of a revision scenario in ACL if the slope angle or if slope is more than 10 degrees or more. So you can combine your ACL with a slope correction osteotomy of the proximal tibia. So these are the more common osteotomies that we perform. There are other osteotomies like closing wedge osteotomies we are not using nowadays, because these osteotomies, all these three osteotomies are, I will tell, this is a ligament friendly osteotomies. So other osteotomies will not correct, they will correct the alignment, but they will not restore the ligament tension. All these three osteotomies are ligament favoring osteotomies. So we are not only correcting the deformity, but we are also stabilizing the knee with ligaments. So we are not also stabilizing the knee. So that is why closing wedge osteotomy less commonly used nowadays, because it will just correct the alignment. It will not correct the ligament laxity or the, because most of the patients with STO you will have a varus thrust. So there are ligament issues also. So you need to address the ligament issues also in these patients. Okay, so these are the three most common osteotomies. that we perform in a ligament sparing or a ligament. These are ligament favoring osteotomies. I would say that way. The other scope is obviously a osteotomy with a fixator or a Visa rope. That is also a very good technique, minimal invasive without use of the